after a couple of decades of really minimal, rather incremental gains in advancing management for stage 3 non-small cell lung cancer, the PACIFIC trial of consolidation Durvalumab really represents what most of us in thoracic oncology consider to be a true quantum leap. This trial gave chemo concurrent with radiation, chest irradiation, at least 2 cycles of platinum-based chemotherapy. And then in patients whose cancer did not show progression and who had good enough performance status, they were randomized after chemoradiation to up to a year of consolidation Durvalumab or placebo. And this trial, initially presented in the fall of 2017 at ESMO, showed a very striking improvement in progression-free survival that at that time did not include overall survival data, which was too immature, but it did show a significant improvement in time to death or distant metastases that led the FDA to approve consolidation Durvalumab shortly thereafter, and led me and most of the thoracic oncology community to adopt this approach as a new standard of care, even while waiting on overall survival. And we got the overall survival data a year later in another New England Journal publication about the PACIFIC trial that showed that the progression-free survival or disease-free survival was holding up, and that that overall survival was significantly better, and not just a little better, but remarkably better. And this has held up with subsequent evaluations of the data and longer follow-up. A publication in JCO in 2022 by David Spiegel and colleagues looked at the 5-year data, and it's an approximately 14% improvement in overall survival at 5 years. So this is I would say, very clinically significant improvement, not just statistically, and it's held up for years after patients have completed their year of treatment. So it's not just temporarily, transiently propped up while patients are on treatment, but seems to be of a very prolonged duration, even years after patients have stopped that treatment. And I would say we should be hopeful that this really represents more patients being truly cured after all of the interventions that they have received for stage 3 lung cancer. And approximately a little more than a third of patients now alive at 5 years, compared to typically around 15% or so, no more than 20% in preceding trials. So it's a real benefit. Now, it's also important over time to kind of refine who benefits more, who benefits less. And the US-based approval is for all patients, regardless of PD-L1 and regardless of whether they have a driver mutation. And this is in a setting where it hasn't been completely routine to do PD-L1 testing or molecular testing. But some of the data, including the unplanned subset data from PACIFIC itself, shows that the patients who don't have PD-L1 staining, if it's less than 1%, do not appear to benefit from Durvalumab. So it's a judgment call whether you would want to recommend this for patients or how enthused you should be if they do have PD-L1 0. It's not to say that it's necessarily harmful, but immunotherapy can have not just acute side effects, but sometimes long-lasting ones, and it's an extra year of therapy and coming to the infusion center all that time and cost. So even if it's not to the patient. So it's a factor to consider whether they're likely to benefit or less likely to benefit. Also, patients with an EGFR mutation, in retrospective looks at the PACIFIC data and other data sets from EGFR mutation positive folks with stage 3 disease, those patients do not seem to benefit from consolidation Durvalumab, and may have a harm if going straight from Durvalumab to osimertinib in the event of progression from interstitial lung disease from the interaction of immunotherapy with Durvalumab or other immunotherapy followed immediately with osimertinib. So it is appropriate now to be a little more refined in our thinking about who is more or less likely to benefit, to have a discussion with our patients and help have them decide how they would like to proceed in settings where they would be technically eligible, but are maybe less likely to benefit and may even have harm from it. I would be very cautious or really want to explore the benefit and risk of Durvalumab in a patient with a driver mutation, who I think are not especially well served, and even patients with PD-L1 negative, but no driver mutation. I think it's definitely worth a good, thoughtful discussion with them about it may not be harmful, but it's not especially likely to be helpful. We need to learn more, but in the meantime, even taking all comers and some patients who are seemingly less likely to benefit, this really represents a quantum leap, far more patients alive at 5 years without evidence of disease.